Kia ora tātou, Boyd Swinburne's my name. I'm from University of Auckland. So welcome to this session on obesity, rising to the challenge. We hope we have something perhaps a little bit different from a regular medical conference for you. And I hope that you'll be able to use your app as well, and you've downloaded that Attentify app and be able to ask questions. They'll be coming through onto my phone, and after the presenters have had their presentation, we will sit down for some Q&A. And so if you can send your questions through, I'll try and be a good chairman and read the questions as they come through. So we've got plenty of time for questions at the end. So let me start. Can I have my slides, please? I've just got a couple of slides because I chaired the RACP working group on obesity. This came out last year, and I just want to make a couple of points. Robyn Toomath was also on this, and she'll cover a bit more of this, but a couple of the key points. Calling obesity a disease, yes, it is a risk factor, but it's also a disease, which I think is an important concept to understand, and even though it has societal and systemic causes. So the different sections in it, RACP is important as part of the public health advocacy. Robyn will probably touch on that. Reducing weight bias, this is critically important in our profession, and we have Izzy who's going to touch on her experience on that. Supporting patients with their weight, which I'll talk about a little bit. Access to bariatric surgery we probably won't talk about. And co-designing actions or working with priority populations, and we have a couple of speakers who are going to talk about what's happening in their community. So the RACP recommendations that when dealing with patients, first of all, weight as a vital sign. Keep taking weight at every encounter within medical interactions. If I go into a GP surgery or go to see a doctor, I expect to get my blood pressure taken. It's just part of the deal. It's a vital sign, and we need to be using weight like that as well for children and adults. First priority about optimising health at any weight, and there's lots that can be done with diet, exercise, sleep and stress and medications independent of weight. Preventing further weight gain is something we all need to do. We're living in an obesogenic world, and so this is not just people at risk, but people in their 20s and 30s as they gain a few kilos every decade, just reminding people about that. And lastly, about carefully considering weight loss attempts, and Robyn will talk a little bit about that. We're all very familiar with the diet, with the weight management guidelines and the evidence which focuses on the benefits from the downswing in that tick-shaped curve. You know, everybody loses weight, all diets work type of thing for a while, and then most people return back to where they were, and so all diets don't work. That second part of it, the potential return and the failure of diets, I think we need to include within the evidence as well. So, on that just short note about the college position statement, I'd like to start with Robyn Toomath. And Robyn, as many of you know, is an endocrinologist. She was president of the New Zealand Society for the Study of Diabetes. And during her tenure, she got seriously into advocacy. She started the activist group FO, Fight the Obesity Epidemic, in 2001, and was a total champion for more than a decade, taking the public health cause, which is actually really important with that doctor's voice. Yes, there are many players, but actually doctors' voices are critical. And then she published her book, Fat Science, Exercise and Diets Don't Work, and What Does. That was published in 2016. Robyn's clinical director in general medicine at Auckland Hospital and president of Internal Medicine Society of Australia and New Zealand. So, Robyn, thank you.
Okay. Well, Boyd, I'm actually not going to talk about the advocacy role at all today. I thought that probably my role in this was to talk as a clinician, because although, as Boyd said, I've been an activist, I suppose, for maybe 15 years, I've actually been a hospital doctor sitting in clinic rooms trying to help people with weight-related problems for just about 35 years. So I thought I would like to give some sort of, a practical description of what I, after nearly 35 years of experience, do, in the clinic room or on my ward rounds for people with obesity. And in particular, I am interested in how we can not cause harm through stigmatisation. So at the beginning, I did as everybody in a diabetes clinic does, or did then, and asked people to lose weight as the solution to not progressing onto insulin therapy or improving their glycemic control. But I stopped asking people to do that about a decade ago, mostly because I thought it was more harmful than helpful. And I'm going to make a confession here, Boyd. I don't weigh my patients, ever. So, just, but that is, other people weigh patients weigh themselves. I don't need to do it. So, in addition, about 5 years ago, it occurred to me that I needed to stop congratulating people on weight loss. And I don't just mean patients, I mean colleagues and friends. And that's because there's a flip side to congratulating people from weight loss. If we're to celebrate and congratulate people for losing weight, what does it mean when they gain weight? Are we scolding them? And of course, actually, in the health sector, mostly we are. Not overtly, but covertly all of the time. All of the time you hear comments that, God, it's a shame that you weren't able to keep that weight off, or, gosh, if you could only lose just a wee bit more weight. Those sorts of scoldings are implicit in so many of our conversations with people who have gained weight. So, doctors all the time prescribe treatments which are pretty hopeless. We're always prescribing treatments that don't work or are actually harmful. Gabapentin is pretty useless for diabetic peripheral neuropathy. Beta blockers hardly ever work for migraine prophylaxis. I'm talking about my diabetes world. Metoclopramide's hardly any good for gastric paresis. But we prescribe this stuff all of the time. And of course, we produce tremendous harm to our old patients whom we prescribe antihypertensives and sedatives and narcotics, often in combinations, causing falls. And sometimes we produce catastrophic events like, intracerebral bleeds in people we put on anticoagulants. And when these things happen to people, when we cause harm, people blame us. They blame the treatments or they blame us. But when we prescribe weight loss, which is done in clinic rooms all over the city, all over the country, and I'm not just talking about in diabetes clinics, I'm talking about in orthopaedic clinics and liver clinics, all over the place, people are prescribed weight loss as a treatment. But when we prescribe this treatment, which is useless in the vast majority of people, so 85% of people who embark on a weight loss program will not have sustained meaningful weight loss at 5 years. When we prescribe this useless treatment, who do the patients blame? They don't blame us. They blame themselves, by and large. And even if we don't blame them, the sense of frustration and shame and disappointment is internalized. The difference about our role in all of this as doctors is that we are particularly well suited to make that so much worse. So I don't think that prescribing weight loss is therapeutic with the tools that we have available at the moment. I think it's mostly harmful. So the question is, what do you do instead? So if I've got patients under my care who've got an obesity-related medical problem, and this happens a lot, I've seen 2 people go into private hospitals with spinal cord compression because they could not fit onto an MRI scanner to identify the site of the lesion so that the neurosurgeons could go in and relieve the compression. But more often, every single day I'm on a ward round, I see people with obesity-related leg edema and recurrent cellulitis. So when people come into hospital with something which is related to weight, I acknowledge that. I acknowledge that in the same way that I might acknowledge, that people with very fair skin and red hair are prone to skin cancer, that people who are very old are prone to frailty-related, age-related conditions. But I acknowledge it with sympathy, or empathy at least. And I then move on and would most often say that I do not expect people to embark on a diet to lose weight, because I do not believe that it is an effective intervention. I will state that at the beginning, and then if it's appropriate, I'll talk about bariatric surgery. It's interesting, the bariatric surgery discussion. For some people, the idea is abhorrent, and no, they definitely don't want to do that. So I mention it, it gets stored away somewhere, and we move on. Some people are just desperate to be given permission to ask for surgery. And quite often, people have never had the option of surgery, bariatric surgery raised before, which I find, very sort of astonishing. I try not to talk about diet. People sometimes ask me about diet, and if I'm going to talk about diet, I will generally limit it to two things. I will ask them if they can possibly substitute sugary drinks for diet-related drinks. And then I ask them to add things to their diet. I ask them to eat as much fruit and as many vegetables as they possibly can, which sometimes mean as much as they can afford. And so, that's pretty much where I leave the discussion, certainly at the bedside on my ward rounds. The trouble is, many people will not opt for surgery, or surgery will not be available to them, or they will be unfit for surgery. So what else do we do? And is it really the case that dieting is never, ever, ever an option? And of course, there are those people who do benefit from diet, and I have to say, I have slightly softened my thoughts about diet with the publication of the DIRECT study. And just last month, I read a review of the Counterweight Plus study. But it's not a study, it's an intervention available through the NHS. Some of you may be familiar with it, but Counterweight Plus is a fully funded NHS program for people who are very overweight. And it's completely funded, so you go a lot, the patients get prescribed Counterweight Plus, and they have 12 weeks of a liquid meal replacement diet. They have 2 weekly appointments with a health professional over this time. They then have another 12 weeks where they are supported onto reintroduction of food, again with 2 weekly appointments. And if they fall off the wagon and start to gain weight, there's a rescue package where they can go back onto a liquid replacement diet. And then they have 18 months, or at the time of this publication, they had 18 months of follow-up, still with 1 monthly appointments with a health professional over that time. And their results were quite good. They were better than we see with, most of the diets that are offered to our patients here. And I think 22% of people had achieved their goal weight of 15 kilograms of weight loss at 12 months. The peak, as Boyd alluded to, the peak weight loss was at 6 months, and they had started to gain weight at a year, and who knows where they would have been at 5 years. There were some extra good bits of information to come out of that, and that was that losing weight fast is good. So the old adage that you had to lose weight slowly is not true, and that if you lost weight sharply at the beginning, that meant that you were more likely to have lost a meaningful amount of weight at 12 months, and also that men were more successful on this program than women. So yes, maybe there are diets that we can prescribe for people that won't be harmful, but you do have to remember that approximately 80% of the people, even on this highly supported, completely funded diet, did not lose weight. So, it's still a pretty useless treatment. And I think if I was to prescribe this kind of regime for my patients, I would say to them right from the outset, no matter how hard you try, probably you will fail to achieve the weight loss that you would like. Even in this program, 80% of people will not achieve this. And ask the question, are you up for it? In the same way oncologists ask patients whether they want to take on harmful chemotherapy. So we have to be upfront with people when we prescribe this kind of thing. So what do we do instead if we haven't really got good diets and people aren't fit for surgery? Well, what we need to do is absolutely optimise health irrespective of weight. Park the weight. Don't get fixated on it. Talk about all of the other things that overweight people are more prone to in terms of their health and concentrate on those. So our patients need perfect blood pressure and lipid management. We need to make sure that, as with everybody else, people are vaccinated, that people are screened for cancer and diabetes, and we need to be alert that some of our very overweight patients present with very subtle signs of dangerous conditions like sepsis and probably ischemic heart disease. But I think more than anything, our patients deserve an empathetic and a realistic response from us. I think we're still far, far too heavily invested in personal responsibility for healthcare generally, and for obesity in particular. We've got to remember that our treatments that we have available are pretty hopeless, And this means that our need for the public health issues, the public health responses that I've been advocating for and Boyd is a champion for, are still the most important things to push for. We need an environment where it's easy for people to eat healthily and to get as much exercise as they possibly can.